Your article is titled Identifying the Prevalence and Causes of 30-Day Hospital Readmission in Children. What inspired you to do this study, and why it is important to measure readmission rate at your hospital?
Great. This is great questions. The study, what inspired me to do the study is that I believe that uh, probably we have our unique socioeconomic status that our hospital is serving the military,
Hmm.
which means the soldiers and their families and their dependents. And I feel that many of those cases may be not truly medically indicated. Um, and there is maybe psychosocial factors behind this readmission that make me to study more a 3 years journey across all regions. So this is not as my only institution, but I mean the corporate level, meaning that I study all cases from Eastern region, Western region, and Central region, looking for the real causes behind readmission. And that will help me to reach to the root cause analysis of those, so we can tackle any preventive measures that help reducing this readmission within our context.
You have a staggering sample size of around, I mean, more than 25,000.
True.
So, which makes the study really valuable. I mean, it's really valuable. So great to see that. It's really inspiring.
Thank you.
What are the key findings according to you, and while you are doing this study?
So, first of all, I thought the rate of our readmission is gonna be exceeding the international figures. You know, the international figures is 6%. Usually, if you look to the pediatric
Hmm.
specifically
Yes, true.
studies, usually they are between 6 and 7%. Our result, it showed that the rate of readmission is below that. It's 5 point something, I think 5.6%. So that's the first surprise to me. I thought we are exceeding, but it seemed to be we are within at least the international figures. That's a bit relieving factor. Uh,
Absolutely.
and what's really a key finding within this study that probably the more than half, I would say around 56% of our readmission is related to the primary cause. So there must be a way to comprehensively address or to develop a checklist um, to discuss, I mean, the readiness to be discharged. Because when you look to that, more than half of those unplanned readmission is really related to the primary cause. So you have a feeling that it can be prevented if there is a robust or close or thorough review to all aspects of the disease, so the patient will not come back to you.
It's really interesting. So you are not just compliant, you are better than developed nations. So you have compared mainly from Australian studies.
Mm.
Uh, so it's really great to see your compliance level.
Yeah, and to be honest with you, I would say that uh, probably there are many outliers that could maybe improve our figures. I'm not trying to undermine our facility or underestimate that, comparing us with the developed country, but generally we have many light cases, I would say, that can be not admitted. And I think this is diluting probably the numbers,
Oh.
to be honest with you. So we have a really simple case. You know, our primary care facility is not really well established. So we have this mentality that even mild URI, sometimes they access to the hospital. I'm talking about triage 4 and 5,
Hmm.
especially in winter.
Hmm.
They sometimes finding their way to be admitted, and when you have those cases that admitted 12 hours or 24 hours only and being discharged and counted as real admissions,
Hmm.
so Those can be, in a way, improving our figures, if that makes sense.
Okay, so it's like daycare or something you're considering?
Exactly. We have an observation unit that we called pediatric acute unit. It is geographically located around the ER.
Okay.
Um, and it is usually admitting the patient for who require admission less than 48 hours. And many of those patients, especially pediatric age group, the length of stay is around 2 to 5, majority of them. So the unit is really busy over the winter. It's admitting light cases, and it's counted as admission. And many of those are well enough not to be readmitted.
Mhm.
So those can be, if we eliminate those type of cases, which is account around 10% during the winter, by the way.
Oh,
This is maybe it will improve, it will make our result a bit more in case of readmission. Has been highlighted as well,
yeah.
that we receive cases. Yes.
My next question to you is how this study or the findings are useful to in a real world scenario. I mean, or maybe if I put this question in another way, how you can, guide or advise uh, other hospital or a similar setup.
Sure. That's a great question as well. So our study really indicate that the majority of readmission is belong to those who have post-operative issues. For example, those with tonsillectomy and other cases. And many of those cases, they are really admitted for, and we prevent this readmission if really there is a clear instruction what to do and what you expect post-operatively.
Hmm.
Sometimes this is being explained, but not really thoroughly. And majority of those patients, for example, those who's post-operatively admission, they freaking out when they say a little bit of blood and all of this. So if you really they receive clear instruction that is really expected, that's good. So probably if that's the surgical side, that probably talking about the expectation post-operatively, this is really something has to be done through a surgical coordinator, maybe a hotline, maybe any way really to prevent readmission. We really lack those post-discharge close follow-up due to the busy system overall. And many of those cases, I believe it can be prevented if there is an implementation of a close post-discharge follow-up, probably involving a home health care visit on those. That's the surgical side.
Right.
Regarding the medical side, majority of our readmission is due to chronic medical condition, which is really my specialty actually, the complex medical care.
Oh,
So those who really, I do believe that our health system is not really designed well to serve this unfortunate population. Our healthcare system is meant to treat acute condition, and all the facility that has been done or designed is meant to be that way. I believe that our hospital leaders overall in the region, they should look for or navigate ways really to design the system for the best interest of those population. Meaning that there must be a dedicated team to serve those 24/7 services, invest more in the primary care or home health care facilities, troubleshoot equipment failures, because those all what the caregiver really struggling with.
right.
And many of those really having financial support as well for them, navigating way through the charity, or because many of those they really desperate and they just end up readmitted, sometime for medical reason and sometime really for pure social reason.
I think I must say, while your primary objective is to study the readmission, but on the way you have find out many observations which are really help your organization and others to improve their service as a whole. So great. So what next? I mean, is there anything you like to highlight for the readers?
So I think for the hospital stakeholders and all interested in hospital operation, I think they need really to customize their resources according to the context of their patients, their population, having more investment on the infrastructure, having teams really specialize in dealing with surgical, you have medical, you need really to really establish a pathway or guidelines. I would say that really standardize the practice. We noticed a really variation in terms of the way that this population has been served. For example, we're seeing surgeons who's really admitting patient one day more, but less risk of readmission. We saw, for example, patient was being linked to the community or home health care earlier, and dedication from the clinical care provider in supporting him distantly. And that's really it's preventing the readmission. In a way or another, there must be a specialized team. Let's avoid really having general team taking care of all, because you cannot really fit the orange like an apple. So orange is orange and apple is apple. So we believe that our patients should be looked as the same. You need really to have really people in the way. I think clinical nurse practitioner is a key here, and will have really a major role really of controlling and improving the figures of readmission, coaching caregivers and having more involving them through the shared decision making, and thoroughly educate them about the nature of the disease and the equipment and when to access medical care and how to reach the medical care, will be really improving those figures.
Right. Great. Thank you so much, Dr. Hamad. It's been a great interacting with you. And I hope that your article and finding will inspire many. And this article and findings will definitely help others to understand what's going on in their healthcare operations and how they can improve from there. And thank you so much from my side. Thank you so much from JQSH and Innovation.
Thank you so much.
Thank you so much. Have a great day, sir.
See you then. Bye-bye.
Bye-bye.